Good morning, everybody. Welcome to the Tuesday morning session. My name's Catherine Gallop, and I'm the co-chair of the PPN in the Southwest. So our session this morning is going to focus in on children and young people's mental health, with a particular focus on the pandemic and what we've learned and how we can help. Next slide, please. So in terms of just a bit of housekeeping, please do let us know any questions. There is the Slido window on the right hand side, so we'll be monitoring questions throughout the morning, and then at the end of the session we'll have some questions and answers so we can pick up on some of the questions that you've got for the presenters. If you're experiencing any technical issues, please do contact webcasting on that email that you can see there. And please do note that this session is being recorded. So if you don't want your name to appear, please post anonymously in Slido if you have any questions. And if you want any more information at the end of the session about where you can access the materials or get your attendance, then please do get back in touch. Next slide, please. So this session is linked to one of our kind of areas in the psychological professions vision, with a focus on helping our communities thrive. So that's our commitment within the vision for psychological professions to help develop healthy, thriving communities with more psychologically informed public. So we're just going to play you a short clip now.
We know. You've seen many a vision come and go. We're trying to do something different here. In 2020, we went on a journey to co-create a more impactful and unified future for the 12 psychological professions so that we can deliver the best possible care and support for everyone in our communities. We had over 1,800 people coming together to share over 12,000 ideas, comments and votes about our vision for the future of the psychological professions and the commitments we must all make to achieve our visionary goals. A vision for the psychological professions. To transform lives and communities by extending and embedding psychological knowledge and practice across the whole of health and care. Here are just some of the commitments. Help our communities to thrive. By working with communities to make services more transparent, accessible, and responsive. Recognize and respond to wider social factors such as poverty, discrimination, inequality, and trauma that can impact on emotional distress. Address national and local disparities in access to and experiences of psychological healthcare, particularly for ethnic minority communities. Now, we want to make this vision real. We want to bring it down from these visionary planets to our blue and green planet Earth and connect it with everyday life. We are calling this process the Intergalactic Bridge. Over the next few months, join us in creating the Intergalactic Bridge. Tell us what's been working for you and your ideas on how to make this real. We'd love to hear from you.
Great, so please do get in contact, link into Psychological Professions in Action, because they're really keen to have your ongoing support and input into how we make this vision and turn it into reality. Thanks, Matt. The next slide. So I'm going to hand over now to Professor Peter Fonagy, who is National Clinical Advisor on Children's Mental Health for NHS England and Improvement, and also the Chief Executive of Anna Freud National Centre for Children and Families. And Peter's going to take us through an initial presentation with a focus on what we've learned about children's mental health throughout the pandemic, and setting the scene in terms of how we can best help.
Thanks very much, Catherine. I'm delighted to be here and delighted to join you in this meeting. I hope that I can help clarify some issues. I want to start with what I knew in a presentation now, I think quite like 18 months ago, more longer than that, at the very beginning of the pandemic, where we really had very little to go on. We had estimates of prevalence from other pandemics and other risk factors that we identified, screening studies, and really initial responses to man-made disasters, to natural disasters. And we, at that point, I was asked to estimate what mental health needs would be as a consequence of the pandemic. And at that point, I put forward the idea that about 16% of those 2 to 18 would be exposed to trauma, that depression would vary somewhere between 7.5% and 45%, that a large group of children, young people would be unaffected, that there would be individual factors, secondary stressors. Some will have delayed onset. Some do not follow the pattern of declining recovery and enduring problems. Basically, when I was pressed, I said, look, there'll be approximately 15% male and 20% female who will have needs associated with the pandemic. That the largest impact would be on adolescent girls, significant symptomatic distress as well as functioning problem, that existing mental health and neurodevelopmental needs would be a particularly risk group, and that there would be disproportionate additional impact on violence. Also stressed that there would be increase in alcohol, nicotine, and substance misuse on the basis of the research that we had available. The logic of that was that many young people would be exposed to things that we know impact on mental health: social isolation, their disturbed daily structure, greater exposure to domestic violence, family illness, homeschooling, parental anxiety, recession, interventions that were likely to require, in addition to those who were directly affected by the pandemic. We also thought that there would be higher COVID-related trauma, PTSD, particularly for 13 to 24-year-olds, and the higher prevalence of a group that we knew were at risk, that was young women at 16 to 24. And there we estimated that the prevalence could go up to 45%. And we also anticipated that the older groups would not be appreciated. Now, this is really interesting because you can actually now look back and say, how accurate were we in our predictions? And it's kind of a curate's egg. In some things we were accurate, some things we were not. Where are we now? This is the bottom line. This is the best available data. What tells us most about what the impact has been are prospective longitudinal studies that had taken a number of samples, a number of waves before pandemic started, that would enable us to do a kind of projection of where they would be were it not for the pandemic. And there are of 453 studies that are population studies of child mental health response. There are 28 that have data before January 2020. The evidence is for a substantial impact on young people's mental health. So there is a marked increase in symptoms of common mental disorders in all but 2 of these 28 studies. The most common predictors of people of this elevated risk relative to pre-pandemic measures is younger age, being female, and having pre-existing health conditions. There are only 3 or 4 studies that have more than one pre-pandemic assessment. So these are studies where we can do individual trajectories of where that particular person was heading. And those are really interesting because we can see who was deviating from their individual trajectory by the pandemic. And these findings, I believe, are the most compelling. The deviations are most pronounced in those with pre-existing mental health problems. And there is, in these individuals, marked distress and a decrease in well-being. That there are these deviations that are not necessarily related to the conventional risk factors. So pre-existing health conditions become quite much more predictive than they would be in population studies. More interesting that the traditional risk factors may not provide as much protection in this context as we had hoped. What it means is that maintaining access to mental health care during future waves is critical, is crucial, particularly for those with pre-existing conditions. Okay, let me just go through some of the data here. And I'll be really quick on this because much of this is familiar to most of you. So there is the ONS survey that had retested individuals tested in 2017, in 2020, 2021, and the data collection has gone down to from over 9,000 to something like 2,500 for those who were there for all these 3 waves. But note that the measures were interviews in 2017 and are self-report or parent-report measures later on. What are the headlines? The headlines are that 1 in 9 has gone up or down, whichever you want to look at it, to 1 in 6, with males about 18-19% and females about 16%. More important that 40% experienced deterioration, whereas only 22% experienced improvement during this period. Of the 17 to 19 age group, the male prevalence is 10% and the female prevalence of probable disorders is 25%. Eating problems turn out to be a specific problem, and that's gone up, doubled in the 11 to 16-year-olds from 7 to 14% or near enough. And in the older age group, it's gone from 45 to 58%. Very interesting that sleep problems are strongly associated with probable mental disorder. Schooling for those who have probable mental disorder is a major issue, but access to laptops have improved. Regular support from schools is increasing, but is still only about 80% for those with mental disorder. Just briefly, this is not a particularly inspiring side, but shows the improved, the increased prevalence. I would want to emphasize the massive number of sleep problems that have occurred and that are strongly associated with mental health problems. Also, that support from schools for households that are less well off is actually lower. And that's a particular risk issue that we have to be aware of. Again, the overrepresentation in the older age group of young women is to be noted. Moving on, from birth cohort studies, I won't linger on, more or less confirms this picture. I've aggregated their results in what I said before. What I want to emphasize from these that older age groups in these birth cohorts, the 1958 and the 1948 birth cohort studies, they do fine, really. Some of them in a post-COVID sweep do better than pre-COVID. So people of my age have done well out of COVID, which is important and relevant for us to notice. It's young people who have had a difficult time. The CoSpace studies perhaps is the most interesting from the point of view of looking at individuals going through this period. There are online surveys, a convenient sample, all kinds of limitations, but a large sample. We don't know what happened to them before, but they were consistently followed through, and some of the patterns are really, really interesting. I would say that particularly concerning is the age difference that CoSpace highlights for us. So there is a strong association with restrictions, but it affects different age groups differently. So in the younger age groups, attentional difficulties, behavioral problems associated with the lockdown, decreasing after the lockdown, is notable. In adolescence, it's a much more stable pattern over time. There are greater changes in parent-reported scores on the SDQ, particularly amongst pre-adolescents. Why is this? The pre-adolescents are more cut off from their peers. And that's, I think, important for us as clinicians to bear in mind. But also that parents are juggling, and many of you would be witnesses to this, but particularly those living in single adult households or in low income, or children who had special educational needs are far more affected. The patterns are similar for boys and girls, but the highest risk are those with educational needs, special educational needs, or neurodevelopmental disorders. Low income and continued to report higher levels as the restrictions ease, so that the pattern is that if you do not have these risk factors, you're affected, but you get better once the restrictions ease. If you have these risk factors, I think you're more affected and the effects continue. Economic hardship, educational needs, parental stress, all these are very closely related risk factors. So it's additive, possibly. Less resources to bounce back amongst in this population. It's important that we provide extra support for these individuals and ensure that differences, inequalities are not widened. And I'll say a couple more words about this. This is a lovely slide from the COVID report summarized in the Lancet Child and Adolescent Health recently, and it just shows very clearly the association with the lockdown, the increasing prevalence of disorder, but also how individuals with lower income and those with special educational needs are above, way above those without those risk factors. I should say that there are individual differences here that the COSPACE study drew attention to. So conduct problems occur, for example, different patterns in different trajectory groups. There are some groups who are unaffected, some groups that who started high in depression and anxiety, who then have higher levels of conduct problems, who also have siblings and from a low income and are more likely to be male. In terms of hyperactivity, there are two patterns. One pattern that start with depression and anxiety, being younger, who are also joined by another group with high family conflict and low family warmth and poor income, who develop these problems. The point I'm trying to make here is that it's not uniform. Emotional symptoms similarly follow four trajectories, and I would, it's a little bit too complicated to present in a brief discussion, but basically the pattern is very clear. Those who start with problems have greater problems and develop more problems. And I am very grateful to those people working hard on identifying this, because it is clinically very helpful for us. The Department of Education's panel report reporting this summer confirmed these findings from 3,000 primary and secondary pupils reported on by their parents, and secondary school pupils reporting themselves. Adolescent well-being was best in the summer of 2020. Then it takes a dip, but it is stable between March and July 2021. Again, older and female is indicative of poorer well-being. Anxiety is associated with the waves of the pandemic. The parents' response mapped closely onto the children's response. So in summary, what can we say? So the evidence suggests that children and young people's mental health and well-being has been substantially impacted due to COVID. That between March and September, some children coped well, and others coped less well. That pre-existing conditions and more negative impacts, and females suffered more. That in September 2020-21, there was a decline in well-being in children and young people, and anxiety had a key impact. And in January through to 2021, an increase in behavioral difficulties, and gradually decreasing after March 2021. Both parents and carers reporting as well as child self-report confirm it. Recently published evidence has really focused on the heterogeneity, but also the emphasis on sample. Now, just to talk briefly about risk factors, special educational needs, as I've talked about before, gender, as I mentioned already. I would say that very clearly 16 to 34-year-old are more affected if they are female, particularly across population surveys. Of course, the UK household survey shows the same thing. I would also say that the youngest age group shows highest unemployment growth, and this cannot be a irrelevant fact in this. I would say the disadvantaged groups have poorer mental health and a bigger response. And as the lockdown progresses, the higher income groups get better, the lower income groups remain affected. Teachers reporting loss of learning is markedly greater in the low income groups. I would also want to emphasize once again that pre-existing mental health conditions are enormously important. There are many, many reasons for this that I don't have time to go into, but there are barriers and challenges that these individuals face in terms of accessing services that indicate that we should be particularly alert and open our doors to them. Finally, the issue of race is complicated, I think because of partly a reporting issue as well. But we do know that Black and African groups are far more affected, even when you are adjusting for age, geography, socioeconomic, and health status. They are more affected by COVID. So we would anticipate a bigger impact on Black African, Bangladeshi, and Black Caribbean groups. The current data doesn't speak to that. I would say evidence also supports that those with lesbian, gay, bisexual, or transgender identities are more likely to be affected. They're more separated, they have more experience, more tension. I think it's unclear perhaps why it's happening. Family relationships turn out to be quite an important moderator. Those with happy families do a great deal better than those with conflict families. In this, I think we once again see that the rich get richer, the poor get poorer. I would also suggest that this indicates to clinicians that families need attention, not just the children under the circumstances. So, for example, the increase in domestic violence is obviously significant here. Also significant is loneliness. Loneliness turns out to be a critical factor, as does anxiety. Why anxiety predisposes to being affected maybe is to do with social media, maybe it's to do with schoolwork, but it also indicates a vulnerability and a protection. Mental health services, I've already said, there's a lack of access to mental health services that's experienced, and additional barriers are experienced by those who are experiencing mental health problems. I feel it makes it doubly important that we open our doors wide should there be further waves. There are gaps in the data. There are gaps, and I don't really have time to go into it. I'm running out of time, but there are gaps on children and young people relative to adults, significant gaps. But longitudinal studies are a gap, and I think we've identified more or less all the ones that there are. There is an important issue of pandemic-related risks that we don't yet understand fully because there's been insufficient data collected, and COSPACE was the best one. And particular subgroups I've talked about. There are probably many other groups that will be identified. There is too little data on people from racialized communities. So where does this lead us? I think it underscores the importance of closing the treatment gap. And that's really, guys, what we are here for. We are here to take a more radical approach where we actually take treatment gap by in the best way we can, seriously understand why they occur, and provide scalable, affordable solutions. And I think the subsequent presentations will speak to this. It's important that we make good use of technological advances, but more important that we make our interventions early, involve parents, involve early intervention, just-in-time interventions when problems emerge, look at early in development, and as well as looking at children and young people having access to interventions that are evidence-based. And thank you very much for your attention.
Many thanks, Peter. Thanks so much for that really rich and helpful summary of the impact of the pandemic on children and young people's mental health. So that allows us to move quite smoothly, I think, over to the next presentations, and we'll pick up any questions at the end, Peter, about your presentation, if that's okay. So please do post any questions, anybody that you want us to pick up in the question and answer slot at the end in relation to Peter's presentation. So I'm going to hand over now to Holly Gay. Holly is a postgraduate research associate within CEDA at the University of Exeter, who's been leading on the evaluation of the children wellbeing practitioner role and the education mental health practitioner role across the Southwest. So Holly's going to present to us the evaluation both pre and throughout the pandemic, and she's going to touch on some of the issues raised by Peter in terms of thinking about what we can do in terms of meeting the need that's been impacted upon by the pandemic, particularly in terms of scalable and affordable early intervention. So over to you, Holly.
Thank you very much, Catherine. As Catherine said, I'm going to be talking about the evaluation with a particular focus of pre and during the pandemic. And in the presentation, I will cover sustainability, access, impact, and we'll conclude with a brief overview and aims for the future. Since 2017, the University of Exeter have trained 6 cohorts of CWP trainees, resulting in a total of 203 practitioners. Of the 164 who finished their training, 78% from 17 services qualified and continued working as a CWP. Services have worked really hard to retain their practitioners by encouraging seniority through participation on supervisors' courses. On average, qualified CWPs stayed in their role for 10 months, but this retention rate varied largely by service, with some CWPs remaining in their posts for years. We've received approximately 8,000 referrals since April 2017. And of these, nearly 6,800 have been discharged. This demonstrates effective movement through the system and effectively discharging referrals in line with low intensity aims. 57% have received 2 or more treatment sessions. And of these, 93% have had at least one paired clinical outcome. We have a really high completion rate aim of 90%, but even this has been surpassed. This slide shows the increased demand for support year on year. The dashed lines are estimated referrals for the end of 2021, based on the trajectory of previous years. Overall, it supports the growing need for our CWP services and expansion of the role. We also separated the data into age groups and can report there was no age group referral count differences during the pandemic. In line with adult IAPT, we know that reducing waiting times improves recovery rates. This graph shows a service by time split, and the data is based on referral to first contact with a CWP. We saw substantial waiting time differences by service type. Those referrals made to our statutory services unfortunately waited longer for first contact compared to our voluntary services. However, irrespective of service type, waiting times during the pandemic were more efficient than those pre-pandemic. Furthermore, 56% of all referrals waited less than 4 weeks for first contact. The largest referral source difference we observed in the pre versus during pandemic time period was between education and self-referrals. Given the national lockdown and the resulting school closures, it's unsurprising that referrals from the education sector have decreased. Importantly, it shows that children and young people are referring themselves when other avenues are blocked. It emphasises the importance of making the self-referral route easily accessible for children and young people, and continuing efforts to raise awareness of mental health supports in our communities. It's worth noting that the arrival of the EMHP into schools may mean that future CWP referrals from the education sector may not reach pre-pandemic figures seen here. This slide shows the outcome upon discharge. Compared to pre-pandemic, a slightly lower percentage dropped out, and a slightly higher percentage was signposted on to another service. This would tend to indicate that our services are identifying the most suitable onward route for mental health support for children and young people. Unfortunately, we don't have the specific data to know where a young person was signposted to upon discharge. So now I'm going to talk in this section, I'll discuss presenting difficulties, anxiety presentations, outcome impact, low intensity interventions, remote versus face-to-face, and group work. A large number of young people present with anxiety or low mood. This is within the remit of the CWP role, and often the presentations are mild to moderate. Just over 40% present above the RCAD's clinical threshold prior to intervention. However, we found no significant differences in presenting difficulty when we divided the data between pre and during the pandemic. We've seen a year-on-year increase in anxiety presentations. At the midpoint of 2021, approximately 800 children and young people had been presented with anxiety. This represents 59% of all referrals. As a percentage, we've already surpassed the previous years, and we expect that figure to rise by the end of this year. Comparing the differences between the number of anxiety referrals pre-pandemic and during the pandemic revealed a significant increase. It indicates that more and more children and young people are presenting with anxiety. Not only have we seen the percentage of anxiety increases, but we've also seen the severity increase too. Particularly on the ARCAD subscales, we've seen this increase in separation anxiety, low mood, and total scores. With the increased time children and young people have spent out of school and at home with parents, it's unsurprising that separation anxiety has shown a large increase. Similar to adult IAP's 50% target, this graph shows reliable improvement has remained far above the 50% target, both pre and during the pandemic. It's also important to note the percentage of no change, indicating that young people maintain their scores rather than deteriorating. These figures illustrate the important impact the CWP role has on children and young people receiving low-intensity interventions. In addition to clinical measures, we want to understand the experiences of children and young people. This data is based on the session feedback questionnaire, and I'm pleased to report there appears to be no differences from pre versus during the pandemic. It suggests remote delivery is meeting our expectations and should continue moving forward. We also want to ensure low-intensity interventions are having a meaningful impact on outcomes. This slide shows 5 of the low-intensity interventions used by CWPs and their mean change score. Overall, there was very little mean change score difference pre versus during the pandemic. However, it should be noted that the ends are much smaller in our pandemic data. We did observe a main effective intervention with behavioural activation showing a higher mean change on the low mood subscale than other interventions, and we're hoping to explore this further. The pandemic rapidly forced a change in delivery methods for all our services. Delivering low-intensity interventions through a computer screen was unexpected and challenging, but our services adapted really well. We wanted to explore the impact of the delivery methods across the ARCAD subscale, especially as moving forward, remote sessions are likely to comprise a significant proportion of sessions for our children and young people. This graph shows remote sessions produce significantly greater mean change on the generalized anxiety subscale, as well as the total ARCAD score when compared to face-to-face. It supports the continued use of remote sessions beyond the pandemic and is really reassuring to know that practitioners can utilize remote or face-to-face and produce similar excellent outcomes. Increasing attention is being focused on group work. Goal-based outcomes are a commonly used measure for monitoring individual progress towards a goal, and they are evaluated on a scale of 0 to 10. GBOs are empowering for young people. They focus on values that are important to them. The average goal difference before versus after an intervention was 4.12. A change score of 3 points indicates a reliable change. And overall, as you can see, 72% made a reliable improvement, with the rest not changing, no deterioration. These findings continue to support the use of group work within the CWP remit and demonstrate excellent, reliable improvement towards personal and meaningful goals for young people. In conclusion, CWPs represent continued sustainability and expansion of the CYP low-intensity workforce. Overall, 56% of children and young people wait less than 4 weeks for first contact with a CWP. Services need to be aware of the changes to their referral routes and ensure self-referral is accessible to everyone. We also need to monitor the severity of anxiety presentations and ensure they are within the remit of the CWP role. Despite year-on-year increases above the clinical threshold, CWPs continue to demonstrate excellent, reliable improvement rates. All low-intensity interventions demonstrate effectiveness, and our remote delivery is shown to be as effective as face-to-face sessions, if not in some instances better. For our future directions, through the support of our mental health support teams, we're beginning to evaluate the education mental health practitioner role. Early indicators from 2 of our services show similar patterns of referral rates, waiting times, and reliable improvement in compared to the outcomes of our CWPs. We hope to apply the same knowledge and resources that we've developed for the CWP programme to our EMHP programme for future provisions. Lastly, I just want to say a huge thank you to all of our CWP services, both past and current, for their dedication, support and commitment to the programme. Thank you.
Wonderful. Thank you so much, Holly. That was such a clear presentation that really summarised the impact that the children wellbeing practitioner workforce has been having across the Southwest, and I know those findings have been replicated across England as well. So it's really positive to hear that. We'll pick up there's a few questions that have come in, but we'll pick those up at the end in the question and answer. So thanks so much. And I'm going to hand over now to our last presentation of our morning slot. So Marku Wood, who's consultant clinical psychologist and also the children and young persons clinical lead at Northumbria, is going to present today on behalf of himself and also Suzanne Moore, who's a senior children's wellbeing practitioner, but unfortunately has been called away today, so has had to pre-record her part of the presentation. So Marku is going to follow on from Holly's presentation and tell us a bit more about how some of these low intensity interventions have been implemented and adapted throughout the pandemic when working with children and young people. So over to you, Marku.
Thanks, Catherine. And thanks, everybody. I think one of the things that the folk that have been presenting today, one of the things that we're really excited about is amongst our CYP suite, these low intensity suite of programs that are making such an impact. Already you've seen today that these approaches can and have made an impact in the pandemic. So our slot today, mine and Susan's slot, is about telling you a little bit about how we've delivered this, what adaptations that we've made, and primarily, of course, Susan's presentation will tell us about the adaptations that she has made as a senior practitioner, as a child wellbeing practitioner. So the context here becomes critical, really. As Holly alluded to, and as Peter alluded to, these approaches, we had no idea how well they would migrate onto the remote delivery. Many trusts you will see. So I work for Tees Eskom Wear Valley Trust up here in the Northeast, as does Susan. And we quite quickly migrated our systems onto NHS Attend Anywhere at the beginning of the pandemic. and tried to pick up the work that we were initially doing and tried to pick up the patients that we were seeing. And Susan and I, these individuals work together in many different teams. So we have the different service structures, as Holly alluded to. Sometimes these children's wellbeing practitioners and these education mental health practitioners are working in discrete teams. Mental health support teams for the education mental health practitioners, where these teams are based into schools directly so that we can intervene really early at those points when children really need us. And children's wellbeing practitioners have been based either between CAM services, traditional more CAM services, or discrete low intensity or getting help services at the primary care level. So the structure that where Susan and I were working, and we've since moved on to new positions, but the structure Susan and I working together was in a generic CAMS team, where I was working as a consultant psychologist, and Susan was working as a qualified children's wellbeing practitioner. So we migrated the resources across very quickly. We worked very hard to move resources across from paper versions to electronic versions, and Susan will tell you a little bit about how we did that. We created new policies and new protocols at speed to try and help protect the young people, make sure their data was protected, and make sure that we could still access these folk. For those of you who don't know our area in the northeast of England here, we've got these dense populations of cities up here, but then we've got these enormous vast expanse of countryside and rural areas with high deprivation. So actually this has provided a platform, which I'll be happy to speak about later, for more work to be done remotely, for access to be improved across these hard to reach areas where individuals were often having to get buses for 2 hours or so to get to the clinic. It's improved access. So we're quite pleased of the rare sort of secondary gains of this very difficult time that we've had. The folk that are included in this talk, amongst others, also set up a group of, or a chain or a sequence series of NHS England webinars, which were giving advice about how to deliver these interventions in an evidence-based way, or our best guess of an evidence-based way during the pandemic. I think one of the things that you will see, and we're really excited about, is that as these brand new roles, the CWPs and the EMHPs, integrate into our network, our psychological professionals network, their experience, their confidence, and their competence continues to expand. And so what I will, I'll let Susan talk in a moment for her pre-record, and then I'll just close up by talking to you about some of the other advantages that we've seen, some of the unexpected advantages we've seen by using these low intensity approaches, even with complex cases. But I'll move over to the video now.
Using low intensity CBT remotely with children's wellbeing practitioner. I'm going to be talking today about using low intensity CBT remotely with complex cases. Intensity CBT targets mild to moderate presentations of depression and anxiety. But what happens if this is used for complex cases remotely? Here is the typical protocol for low intensity CBT. So we would start with an initial assessment session with the young person and their family, which would last around 30 to 45 minutes. The second session would include a 5 areas formulation, where a therapist and a young person would discuss the difficulties in more detail and look at thoughts, feelings, and behaviours. Once this is complete, we can offer a psychoeducation session that's specific to the difficulty that the young person is facing. Once we've done these 3 elements, we can then move towards a 6 to 8 week treatment session, which could be behavioural activation, graded exposure, parent-led CBT, or worry management. We would also offer a relapse prevention and discharge session once this is complete. So when working with complex cases remotely, what changes with the protocol? Well, typically the protocol would stay the same, but there would be additions to consider. One of these would be to discuss the options with the young person and their family around telephone appointments and video appointments. It's important that the young person and the family know the pros and cons of each. And it's important that we problem solve any worries and discuss any anxieties that they may have when using these platforms. We've had more success using video calls as we get to see the young person's presentation and pick up on any non-verbal cues, just like you would in a face-to-face treatment session. However, we know that this is quite overwhelming for some young people, and therefore they would prefer a telephone appointment. So it's important that the young person feels comfortable with their treatment. One way we can manage either option is by sending out resources so that the treatment is planned and prepared for. So a therapist can send the worksheets out prior to the treatment starting, which will include resources for in session and also between the session. We can also refer to helpful websites for young people and their parents as well. And looking at resources, we can think about ways to make them interactive during the session. When using video call, you can share your screen and complete these tasks together. So here are 2 examples of a 5 areas formulation and a values worksheet that's used in behavioural activation. Now, these can both be completed collaboratively during the sessions, and a copy can be emailed over once these are complete. It's important, if there's any additional complexity, that there is regular supervision and team discussions in place. Because low-intense ECBT typically works with mild to moderate presentations, it's really important that there's a team around the child to support the low-intensity ECBT, as this just focuses on one area at a time. We can also ask for additional supervision sessions to make sure we problem solve any concerns and worries and manage risk well. There have been a number of difficulties faced during the pandemic and remote working. One difficulty is not being able to see the young person's presentation and to pick up on any non-verbal cues which you would pick up on in a face-to-face appointment. One solution for this is to encourage the use of video calls. Now, there can be a lot of anxiety around video calls, so it's important that we talk about this and problem solve this in a helpful way. For example, during the first session, a young person may keep their camera off, but still use the screen to look at their therapist. And as time goes on, the young person may feel more comfortable to turn their screen on. We know that from working from home as therapists and as young people that there are problems with connection and signal. So what we need to try and do is problem solve this, think about the best place for the young person to complete their treatment, and to offer them any additional time that may have been missed due to these difficulties. Now that parents aren't bringing a young person to the session, it can be more difficult to feedback to parents and to get feedback from them. Therefore, if they're not around at the agreed session time, it's important to arrange additional time to speak to them about the young person's progress if this is appropriate. We know that when working from home, young people may be in busy households with pets and siblings and parents. So we need to problem solve the best place for them to have their treatment in a safe way. A lot of young people teach for the therapeutic bond and getting to know their practitioner when working from home. One way to manage these difficulties is by holding a getting to know you session. So an additional session outside the protocol where you could complete a game online or ask some questions, and the young person can ask you some questions so that they feel more comfortable. Missed appointments has been another difficulty faced, as a lot of young people aren't reminded by their parents anymore because they don't have that travel time prior to the appointment. So it's important that we plan and send letters out with times and dates, and also to send any reminders if this is going to be helpful for the young person and their family. Now, when working with complexity, it's important that low intensity CBT practitioner manages risk well. As a therapist, this can feel more difficult to contain remotely, and young people may have more control over turning off their screens and ending the session. It may be that parents aren't home during the session and that they may not have anyone to talk to after the session. So it's important that we problem solve any of these concerns with the parents prior to starting the treatment and thinking of the best time for the young person to have their appointment. It's important that we have online safety plans where we can share our screen or email over, and to speak to parents, the team and supervisors about any risk, just like you would in a normal session with someone with mild to moderate presentations of depression and anxiety. But why does it work? So for many, low intensity CBT has worked really well remotely. Now, first of all, the treatments that we offer are very structured and follow a strict protocol and plan. Because of this, we can plan for sessions and send out resources before the treatment starts. We can answer any questions about the worksheets and make sure that a young person has access to all of these, either via a paper copy or via online. The shorter sessions of 30 to 45 minutes fit into a young person's day-to-day life easier, and young people feel like they're managed to kind of find the time to do this and also find the time to do the additional homework needed. We know that worksheets online can be made interactive to be completed in a collaborative way during the sessions, and a lot of young people like the fact that they can request control and change things during the appointment. Routine outcome measures would be typically completed in the waiting room prior to the session starting. However, with remote working, we can complete these online together, either on the phone or on a video call. And this can help aid a lot of to create low intensity remote working. It's important that you discuss and decide a plan that works with the young person and their family, to problem solve any worries that they have and to discuss any anxieties that they may be managing. We can send out resources ahead of sessions and be planned so that a young person knows what to expect. We need to attend regular supervision, but also ask for any additional supervision needed when working with complex cases with the clinical supervisor or with the team around the child. ROMs can be completed together during the session, which helps aid a lot of discussion. And many families have told us that remote working is easier on them as there's no travel time. All points I'll be taking forward in my new role in COMBAT, which stands for Community Behavioural Activation Training. COMBAT is a 5-year research study with the University of York, Tees Esconwell Valley NHS Foundation Trust and Hull York Medical School. COMBAT will be implementing low intensity behavioural activation into schools and charities. And this work is based on Macaulay's research in America. The main points that I'll be taking forward in this new piece of research is to provide young people with choice over their treatment. Young people will be offered telephone, face-to-face and video calls depending on the service that they're in. We've also created a digital copy of our treatment manual so that young people can complete their homework tasks online. anyone has any questions about low intensity working remotely and with complex cases, please contact me on my email address. And if anybody would like more information on the new combat study, please see the website below.
Thanks very much, Susan. Lovely. Okay. So what you've seen today is that young people have likely been impacted by the pandemic, that these very exciting new psychological professions can be very effective, and a little illustration there of how the great work that Susan and her team, the great work they're doing is being adapted to working with young people remotely. I guess there have been some challenges along the way that I want to discuss with you, and I'll wrap up in a few minutes, and then I think we're going to plenary. What we're discovering, these really exciting opportunities where evidence-based, manualized treatments, as Susan mentioned, can be delivered to individuals with really quite complex presentations. So Susan and I, amongst others in our team, have piloted under very clear, strict supervision, but using very clear protocols, working with looked after children who might have had a very difficult and complex and traumatic background. Using graded exposure in very complex cases where individuals might be quite risky or have difficulties regulating their emotions due to many, many reasons. So what we've been looking at is that, yes, these interventions can be delivered remotely, and also probably they can be delivered remotely with individuals who otherwise we considered might not be suitable for a low intensity intervention. Now, I just need to reiterate again that that's only appropriate because I, as the consultant psychologist, maintain the governance. I maintained the wider formulation and the wider MDT working. And as Susan emphasized, with clear supervision and with clear MDT working, we might be able to take some of these roles into more intensive work. And there are new roles, psychological roles, that are being developed as we speak that will be working with those more complex young people. So supervision is very important, managing distress and concerns and worries amongst the young people, their families, and the therapists, making sure that they are confident and competent to deliver these interventions remotely, are all really, they're key at any moment, but really key remotely. We need to make sure, as Susan mentioned, that we're able to, as best we can, catch some sort of sight of these kids, look them in the eye where we can. We need to manage risks about who could be in the room with me here, whether if we're thinking about toxic members of the family, we need to try and make sure that we're aware of where these young people are, who could be around them, and how to manage those risks. So we need to also put extra protocols in place, which we have done, but this is a work in progress. Okay, so thinking now about the end of my presentation, my summary is that these are great roles within this great week of psychological professions. They can be utilized remotely, and that they can potentially be utilized in these exciting complex cases as well. Thank you very much.
Hi, all apologies there. I think I had some problems with my speaker. So thank you so much, Marco, for that really helpful presentation, Susan, as well. It was really great to hear a bit more about what it's looked like in practice over the pandemic, and some of the adaptations that have been needed around remote delivery, working alongside children and young people. So we're going to go to full panel now to pick up some of the questions that have been coming in from people that are watching today. So welcome back, everybody. So I'm going to go through some of the questions, and then Ian, just put your hand up if you fancy answering this, if that's okay. So the first one that's come out that's been quite popular in terms of votes is based on some of the data, Peter, that I think you were potentially presenting. Should we be prioritising evidence-based interventions for sleep problems as a first-line interventions, for example, CBTI? Peter.
I think correlational data is always dangerous, but it does seem that sleep disturbance is an early indicator of mental health problems. That doesn't, of course, mean that by dealing with the sleep problems, you will actually change the trajectory of the individuals and avoid the mental health problems. It's a correlation does not imply causation, as I was told when I did my undergraduate psychology course. So it's something that we should look at seriously. And if somebody wants to do a study of taking half the people that present with sleep problems and dealing with it early, does it avoid later mental health problems? My guess would be it would, but I don't know the evidence that would prove that that's the appropriate course of action. I'm just being cautious.
Okay, thanks, Peter. Mark or Holly, anything to add to that one?
No, I don't think so.
No. Okay. So the next question that's come in was asking a bit more about how some of the families might have differed in their responses during the pandemic. And the question was whether we could learn from any of the behaviours that perhaps had a more positive impact on children and young people. Peter.
I don't want to hog the discussion space in any way, but I do think that some of the COSPACE data on families is really interesting, but there are other data that are coming in as well. But broadly, what it shows is that more conversations, the kind of deeper conversations that families had in relation to COVID and other issues that were going on. Children, as young people's mental health has benefited from that. So the children who had closer relationships, being the lockdown made them closer still. Children who had relationships that were conflicted drove them further apart. And one of the major findings from the pandemic that nobody, to my mind, fully understands is why eating disorders, particularly urgent cases, acute cases, doubled in prevalence, and 2/3 of non-urgent cases. So eating problems have increased, but also the presentation of full eating disorder actually increased very, very substantially. That didn't happen with any of the other disorders. No one understands this, but I think it's possible to understand in terms of family dynamics that in young people who are perhaps particularly sensitive to feeling controlled or issues of control, self-control, being controlled by others, finding themselves in a restricted environment, need extra space if we are to avoid that. I think that actually seems to me to have a reasonable change, theory that's associated with it, so that we should be alert to individuals in those kind of family dynamics for whom we know that an excessive sense of being controlled actually might switch them to something that was clinically dangerous, that allows them to spiral and get worse and more difficult to treat. But there's an enormous amount of research to be done on this. I just wish we don't have another pandemic. I'm done.
Great. Thanks, Peter. Anything Marco and Holly wanted to add in relation to that?
No, I think there's been a lot of learning in the pandemic. All of the things we mentioned in our presentation, all the things that Peter represents, certainly in CAMHS, and Children and People's Mental Health Services, we're seeing that on the ground anecdotally, that these young people emerge with terrible disorders around eating, or terrible difficulties around eating. And I think you're right, Peter. I think there is an element of control here. I think there is an element of that, the pandemic, that has really focused that distress and that reaction to distress. I think that there has been an enormous amount of learning about, I think if we don't use this as an opportunity to continue to expand services, I talked about the enormous rural areas up here in the northeast and Yorkshire and Cumbria, and I don't think if we don't build on that and use what we've learned, we've missed a trick. So a lot learned.
Okay, thanks, Marco. So there's a couple of questions that I think came out as a result of your presentation, Holly, which started to touch on sustainability and retention of the children wellbeing practitioners in their roles and in the services in which they trained. So a few comments on saying that the average retention of 10 months feels, quite short, and whether there is anything being considered to improve the retention of CWPs in their roles.
Yeah, definitely. That was, I think that was a bit of a surprise for us as well when we looked at that data. But it is worth mentioning that that's based on all of our services. I think we've got about 20 services now, and some of our services are far more established than others. Particularly our voluntary services. They've been running from the very beginning, from 2017. And their retention rates of our CWPs are long, are years and years. So that data also included our newer, most commonly our statutory services, and those that only lasted for perhaps a year long. So that's why that is such a short amount. But I think one of the main things that's been actioned over the years in terms of the CWP role is progression into the role and progression into seniority, and that's been really important. The South West in particular was able to train supervisors who were CWP trainees, so qualified staff acting as supervisors, to train the next role, and it enhanced the low intensity workforce, supported those low intensity aims and values. And also it's there have been other progressions as well. Looking at a high CWP role. I'm sure Catherine could probably explain far more about that. But I think the importance is in being able to support our CWP services to sustain the CWPs that they've got, progression, and also increasing the role. Yeah. I hope that answers the question.
That's lovely. Thanks, Holly. And I'm going to take that question back to to Peter and Marco as well, if that's okay. So both, I don't know if you have any further reflections from the other areas of to support and sustain the CWPs, but also perhaps national picture, Peter, in terms of developments that are hopefully coming through. Marco, you want to start?
I'll just say ditto first, and a little bit extra, and then hand over to Peter with the national context. So. Holly, you're absolutely right. Susan, who presented today, is a prime example of a talented CWP who's worked through to a senior role, who's developed as a supervisor, who's trained as a supervisor, and now is actually working as a senior CWP within an enormous research study as well. So there really is scope. She's working both clinically and in a research role. So I think one of the important points that that a few of us, led by Peter and co, have really identified is that we needed to be able to promote these individuals, to be able to give them a sense of a career, a purpose. And it might be, I mean, our data is similar, Holly, in the Northeast, but sometimes we see those folk moving in 10 months across to another service, or sometimes we see them moving on to and staying within psychological professions as well. So there's a lot of scope there. And they're not always moving, hopefully, to brand new industries.
And I think that would back up data from the Southwest as well, that even if there has been movement outside of those roles, they have stayed within children and young people's mental health within the region or nationally as well. Thanks, Marku. Peter, any final reflections in terms of that question from the national perspective?
Well, just that some of us, you particularly, Chair, implicated in this, I'm afraid, have worked tirelessly to try and achieve this. And if, you know, Holly, if this is achievable, then it will be achieved if the people in front of you are anything to go by. We are all committed to it.
Absolutely. So, audience, just to sort of add to that, we've been working collectively to try and think about the accreditation of CWPs and the education mental health practitioners, and also individual registration for them as well. And there are other national developments that will hopefully be taken forward in terms of senior role training and further top up for CWPs as well. So sustainability is very much on our agenda, and we're really wanting to support this important workforce, continuing to have the impact that they have. Okay, I think we've probably got time for one
Catherine,
more question. Yeah, sorry.
I just want to give a shout out for you, Catherine. You have worked harder than anyone else. So much of that work is down to you. So kudos to you.
Thank you, Peter. Thanks ever so much. Okay, so last question from me. Let's just see which has had sort of popular votes. So there's a question around the role of social media that I know we're often thinking about within children and young people's mental health. So the question is, what role is social media playing in CYP mental health currently? Can it be seen as a protective factor or harmful? And how can children and young people be advised to manage their social media use? I don't know if anyone's got any thoughts on that one.
If Mark, I've been talking too much, so I'm happy if Mark who wants to address it, or Holly, I'm happily give way.
We'll take it home.
Okay.
I mean, the evidence is that part of the increase in prevalence is associated with increased screen time in the pandemic. Certainly, the age difference, the younger people being more affected by the lockdown, might have been part of the lack of the pro-social aspects of social media in their lives compared to the older ones who are actually were affected by the more pro-social aspect that kind of protected them, better connect, social networking. Loneliness, being alone with the screen is a very different experience from being together with others on the screen. So I think social media is a terrible term. I don't think there's any doubt that social media has adversely affected children's mental health. I say that because now the more information released by Facebook and other providers supports that. But there is a lot of research that needs to be done, because screen time on its own is not a good indicator of social media use, that the quality of social media seems to matter, which I think the pandemic highlighted. So I think the kind of extension of remote mental health practice that both all the speakers spoke to shows just how much potential there is in social media for mental health, but we need to control it better.
Okay, that's great.
Totally agree.
Okay,
Totally
sorry,
agree.
Marco.
Oh, totally agree. We need to know what we're looking at, don't we? Because we know that increased connectivity is really important. We've got studies going on up here about the introduction of the 5G network into our very rural areas up here in the northeast, and connectivity undoubtedly can have major positive impacts on a family. And Peter's right to say that we need to work out we need to be able to discern what is helpful and what is not. And we need a lot of more research to work that out. But I totally agree that overall, social media as a construct hasn't been very helpful in helping kids manage the stress. It's increased and created a platform where individuals who may or may not have become distressed in the first place to have that platform to feel much more distressed.
Okay, brilliant. So thank you all so much. I'm going to draw us all to a close now and just do some final slides around the evaluation to the audience. But thank you so much for your contributions. It's been a really rich morning and really great to hear the different perspectives in terms of research, but also implementation and evaluation as well. So could you put the next slide up, please? So just a reminder, you saw the video earlier, we are so keen to have your input into psychological professions in actions, and really want to have your views in terms of how we turn this psychological professions vision into reality. So please do link in. We're really keen to have your engagement in that process moving forward. And next slide, please. So finally, don't forget you can download your certificate of attendance for this session. So please do click the button at the bottom of your stream window and make sure you download the certificate before you leave today. And also just to say that we've put some evaluation questions into the Slido window. So it'd be really, really helpful to have your feedback by clicking on that option and then submitting your responses. So thanks again to the presenters, and thanks everyone else for joining us this morning.